Good afternoon, and I am really thankful to organizers, especially Dr. Basi, to invite us here for this talk. I am going to talk on fasting and feasting in diabetes. Fasting is an important spiritual aspect of many religions such as Islam, Hinduism, Jainism, Judaism, etc. Depending on the religion, fasting will last for different length of time. In Hinduism and Judaism, there tend to be individual days of fasting. However, the Islamic month of Ramadan, where Muslims fast during the daylight hours, is one of the longest period of fasting, and it is followed by feasting. So I am going to restrict my talk to this only. According to the EPIDA study, which was carried out in 13 Islamic countries where more than 10,000 individuals were studied, and it is the biggest study as far as the Ramadan fasting is concerned, they say that 43% of patients with type 1 diabetes and 79% of patients with type 2 diabetes fast, leading to the estimation that some 40 to 50 million people with diabetes worldwide fast during Ramadan. During fasting, if you see, look at the pathophysiology, the circulating glucose level tend to fall, leading to decreased secretion of insulin. At the same time, level of glucagon and catecholamines rise, stimulating the breakdown of glycogen, while gluconeogenesis is augmented. If the fasting is protected for some time, then glycogen stores become depleted. This, along with low levels of insulin, leads to increased fatty acid release from adipocytes, which again leads to oxidation of fatty acids, which produces ketone. Ketones are used as fuel by skeletal and cardiac muscles, liver, kidney and adipose tissue, and they spare the glucose for continuous utilization by brain and erythrocytes. In type 1 patients, there is a defective epinephrine secretion due to defects because of recurrent hypoglycemia and also because of autonomic neuropathy. When there is a severe insulin deficiency in these people who fast, because of low level of insulin and due to prolonged fast, there is excessive glycogen breakdown. There is also increased gluconeogenesis, ketogenesis, ultimately leading to hyperglycemia and ketoacidosis. From fast state to brief fasting to prolonged starvation, the transition takes place through interplay of metabolic, glucoregulatory and hormonal mechanisms, and it is divided into 3 states. One is post-absorptive phase, which lasts for 6 to 24 hours after beginning of fasting, which is followed by gluconeogenetic phase, which is from 2 to 10 days of fasting, and then it is a protein conservation phase, which is beyond 10 days of fasting. There are certain categories of patients who are having definitely very high risk when they fast during Ramadan, and this fact has to be clarified to the patients. Those patients who are having very high risk are patients who have severe hypoglycemia within last 3 months, patients who have a history of recurrent hypoglycemia or hypoglycemia unawareness, patients with sustained poor glycemic control, ketoacidosis within last 3 months, type 1 diabetes, acute illness, hyperosmolar coma within 3 months, patients who perform intense physical labor, pregnancy and patients on dialysis. Those patients on high risk, not very high risk, those are patients having moderate hyperglycemia, patients with renal insufficiency, advanced macrovascular complications, living alone or those who are treated with insulin or sulphonylurea, patients having comorbid conditions, old age with ill health and drugs which affect mentation. Those patients who are in the category of moderate risk are well-controlled patients who are treated with short-acting insulin secretagogues such as ripaglenide or netaglenide, and those patients who have extreme low risk during fasting are well-controlled patients treated with diet alone or those on Metformin or glitazones and who are otherwise healthy. So these 4 complications are noted in the Ramadan because of fasting. One is hypoglycemia, second is hyperglycemia, third is diabetic ketoacidosis, and fourth is dehydration and thrombosis. Hypoglycemia we all know decreased food intake is a well-known risk factor for development of hypoglycemia. As per EPIDAS study during Ramadan, there is an increased risk of hypoglycemia which is severe enough to need hospitalization in 4.7-fold increase in patients with type 1 diabetes and 7.4-fold increase in patients with type 2 diabetes. Hyperglycemia, there is no information linking repeated yearly episodes of short-term hyperglycemia like 4 weeks duration which leads to any long-term complications. But there is a 5-fold increase in the incidence of severe hyperglycemia which requires hospitalization during Ramadan in patients with type 2 diabetes, and approximately 3-fold increase in patients which require hospitalization with or without ketoacidosis in type 1 diabetes. And this hyperglycemia surprisingly many a times because of excessive reduction of dosage of medication to prevent hypoglycemia. Diabetic ketoacidosis patients on type 1 have increased risk of development of DKA, especially if they were grossly hyperglycemic before the fasting. In addition, the risk of ketoacidosis may be further increased due to excessive reduction of the dosage based on the fact that they might have lesser requirement because of the lesser food intake. Limitation of food intake along with that hot and humid climates, physical labor, over and above that hyperglycemia which leads to osmotic diuresis, all can contribute to volume and electrolyte depletion which may lead to orthostatic hypotension, syncope, fall and injuries. Increase in clotting factor or decrease in endogenous anticoagulants and impaired in fibrinolysis all have been noted because of the dehydration and hyperglycemia. Management of these patients does require individualization because all patients are on different modes of treatment and have different restriction in their calorie intake. So individual approach is to be maintained. But important thing is whether it is a type 1 or type 2, if they are fasting, frequent monitoring of glycemia 3 to 4 times a day is advised. Nutrition, as we know, these patients fast and then they have binge eating when they break the fast. So in that they eat diet rich in very high fat and carbohydrates. So that should be avoided. Those patients should be advised to take simple carbohydrates in the evening meal, and pre-dawn meal which they take, they can take complex carbohydrates. Exercise is as per regular habits, but if they pray multiple times, that also is a part of exercise. And breaking the fast, if they have symptoms of suggestive of hypoglycemia or the blood sugar levels go down below 70, they must break the fast, and that is to be reiterated. Patients who are having diabetes, if they intend to go on fast, they should have a pre-Ramadan medical assessment before 1 or 2 months, which includes glycemia, blood pressure, lipids. They have to be explained of the risk and change in the diet and medication. Educational counseling for the self-care, symptoms and signs of hypoglycemia and hyperglycemia, sugar monitoring, meal plan, physical activity, medication administration, management of acute complication, over and above that, adequate nutrition and hydration. These all things are very important, have to be explained. Type 1 diabetes management, they are having high risk of complication. So they should be given 2 daily injection of NPH or intermediate. Along with that, short-acting insulin at meal times, or they can use 1 daily injection of long-acting insulin, glargine, or twice daily injection of datimir, along with mealtime supplement of short-acting insulin or insulin alaron. Another study also has shown use of glucine, glulicin, lispro, aspart instead of regular insulin as a part of meal-related supplement. And a continuous insulin pump would be an ideal or appealing strategy in type 1 diabetes. Management of type 2 diabetes, we must distribute the calories over 2 to 3 smaller meals, modified exercise program, and care of blood pressure and hydration. Metformin is safe, so 2/3 of the total daily dose before the sunset meal and 1/3 can be given before pre-dawn meal. Sulphonylurea, we know that there is an inherent risk of hypoglycemia. Nevertheless, they are used worldwide because of low cost, so they can be given with caution. Short-acting sulfonylurea are better because there is a less chance of hypoglycemia. Glucagon, they don't cause hypoglycemia, but they augment the action of other drugs. But we must remember that if we want to switch over, then it would take 2 to 4 weeks for the glycemia to act. Alpha glucosidase inhibitors are better, don't produce hypoglycemia, but have a low efficacy, so have to be used in combination. DPP-4 are the best tolerated drugs for treatment of diabetes. They are moderately less effective in A1C reduction, but they don't require dose titration, and they have a potential role as sulfonylurea substitutes. Incretin-based therapy, those who are on newer drugs, they are not also associated with independently hypoglycemia. Exenatide has less effect on fasting glucose, but liraglutide has better effect on fasting glucose, but both will require dose titration. Those patients of type 2 diabetes and on insulin, the management is same as type 1 diabetes, though incidence of hypoglycemia is less. So judicious use of long-acting insulin with meal-related short-acting insulin is an ideal plan. They all will require meal-related short-acting insulin. There is some evidence that use of rapid-acting insulin analog instead of regular insulin before meals is associated with less chance of hypoglycemia and better postprandial control. In a recent study, use of premixed Lispro 50-50 for the evening meals and 30-70 in the early morning meal was associated with better improvement in the glycemic control. Insulin pumps, again for type 2 diabetes, also are option if patients are already on it. Hypoglycemia is very much less in those patients. So basically this is a chart which is not very well seen, but only thing is if the patient is on long-acting sulfonylurea, you can use the same dose in the evening meals, but cut down the dose to half in the morning dose. Pregnancy, patient should be asked to avoid fasting because there is a chance of hypoglycemia which is more. Women with pre-gestational and gestational diabetes should be strongly advised, but if not, then preconception care with emphasis on control. Counseling about maternal and fetal complications associated with poor glycemic control must be explained. It would require multidisciplinary approach and appropriate diet and insulin therapy. So to conclude, I would say that a patient's decision to fast should be made after ample discussion with his or her physician concerning the risk involved. Patients who insist on fasting should undergo pre-Ramadan assessment and receive appropriate education and instruction related to physical activity, meal planning, glucose monitoring, dosage and timing of medication. Further research is needed to help expand our knowledge concerning the risk and management issues related to fasting in patients with diabetes, because there are not very many studies available, and I thank you all for patient hearing.